I love peptides because they are compounds that speak to our entire body. So what I love about peptides is by giving it for improving cellular efficiency, improving overall health, it improves multiple different systems. And that goes for testosterone too. I focused on estradiol, but women lose testosterone too. And even though you don't have as much testosterone as men, it still plays a vital role in your metabolism.
I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 19 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Ayık Kafa podcast. Welcome to Soberhead Podcast. This week, we're tackling the world's #1 killer, heart disease. My guest, preventive cardiologist Dr. Abid Husain, unpacks why plaques start building decades before the first chest pain, why women's risk skyrockets after menopause, and how the sign of heart attack can look totally different in men versus women. We'll cut through the noise on cholesterol, when it matters, when it doesn't, and the statin debates that divides doctors. You'll hear how chronic inflammation and everyday habits quietly shapes your arteries, why screening needs to begin long before your 40th birthday, and how targeted peptides and hormone support may become the next frontier in cardiac care. By the end of this hour, you'll know the lab tests to request, the lifestyle levers with the biggest payoff, and the simple daily moves that keep your heart beating strong. A huge amount of people who watch Soberhead frequently are not subscribed. So I will ask you a quick favor. Hit that subscribe button now, because when you subscribe, it helps us to make the show better and provides better access to the world-leading experts. I'd like to thank Gedik University and Gedik Foundation for their trust in Soberhead Podcast. With their support, it is possible for us to bring you this content at this quality for absolutely free. Our host for this episode is .sub, the space, community, and platform where creatives, experts, and entrepreneurs come together at the meeting point of continents, the Bosphorus. Follow the link in the show notes for more information about events and membership. Subscribe, like, and share, and I promise to continue to bring you a better Soberhead every day. Dr. Abid Husain, welcome to Soberhead Podcast. This is a very important topic that we're going to talk about. And I guess after all the researches that I did, very misunderstood, including me, we're going to be talking everything around the heart. Luckily, it seems like I don't have a heart disease, but it seems like it still is the #1 cause of death of humanity. Say.
First, thank you for having me. It's a pleasure to be here and grateful for the opportunity. Yeah, heart disease is still the #1 killer in globally. Nothing that kills more people globally, for sure. It far outweighs cancer and infectious disease. When we look at the statistics, the number of people that die of heart disease is actually greater than, the number of people that never make it to the hospital and just die before they even get treated is astounding. About 50% or more of the people that die of heart disease never even get to see medical treatment. I mean, these are people that just get missed when it comes to the screening.
It's interesting because, I never hear with cancer, like you said, or any other disease, that there's a long-term treatment that we hear. Such and such had cancer or have cancer and they're in treatment. Whether it goes good or bad, but there's a length. You don't suddenly die. For some reason, dying of a heart disease is it's suddenly oh, this person died of a heart attack. I'm just it makes me think now, how come they don't know about what's coming?
Yeah. Most of the time, it's because they haven't been screened well enough, and they haven't done all the testing that needs to get done. What we're seeing now is that screening is more than just a couple of lab tests. It involves multiple lab tests and often pictures, imaging of the coronary arteries. And it's also the nature of how atherosclerosis develops and where it develops. We do see young people die of cancer suddenly because it may be something that's fast growing and it's in an area that doesn't get detected until it's too late. There is some similarity there when you look at atherosclerosis. Atherosclerosis can be a rapidly developing disease, and rapidly meaning over years to decades. But what we do see is that the way plaque develops, the way atherosclerosis develops.
So is it like plaque on the arteries?
Yes, plaque on the arteries.
For people to understand better.
Yeah, plaque. So plaque is a combination of cholesterol and calcium and inflamed sort of immune products. I mean, you could even imagine it as pus. And it develops underneath the lining of the arteries, and it can develop fairly quickly. It can develop over the course of a few decades. But what happens is the body will adapt, and this plaque will grow, and it will get to a point where it is metabolically active, and your immune system will make it irritated, and it's almost like a pimple inside the artery, except it takes decades for it to develop. And then what will happen is it will get so irritated that it will burst, and that bursting is what causes the heart attack, because then that bursting of the plaque of atherosclerosis triggers blood clotting and platelets, and all of a sudden that will suddenly block the artery. And depending on the artery, because we have three main arteries that feed the heart, one of those supplies the most amount of muscle, and that's often where plaque develops, and that's why when that one gets blocked, it causes people to die suddenly.
Oh, because related to the muscle?
Yeah, related to the distribution, how much muscle is being supplied. Because what happens is if a large artery gets blocked and it closes down and it doesn't supply muscle to the heart, all of that tissue of the heart will die. All of that muscle will die. And so that causes a whole series of problematic events. It'll cause arrhythmias. The heart won't pump well. It may stop pumping. And then, that will lead to death.
I was doing some researches before our podcast to understand the difference between the genders. And somehow I thought that I hear more men having a heart disease or die of a heart attack, but it seems like women's are equal, if not more, face heart disease. And I want to add on to this. For so many other illnesses, from Alzheimer's disease, again, to cancer, to any type of neurodegenerative diseases, obviously diabetes, so many things that we speak in the longevity arena. It's always cautioned people by you have to pay attention to your lifestyle. But we don't hear that for the heart disease. I mean, somehow heart is acting by itself there, and you kind of cannot, yes, when you're so fat and when you have too high of a cholesterol, whatever you consider too high, yes, then it starts getting the attention. But other than that, I don't hear enough people suggesting lifestyle changes, or not even changes, to pay attention to your lifestyle in order not to get it. What are the causes that people end up with a heart disease then die?
Let me take a step back, and because there's a lot that we can talk about there. When we look at some of the gender differences in developing atherosclerosis, one of the time frames where atherosclerosis starts to accelerate in women, and one of the reasons why we think men have more atherosclerosis in the younger years, is because men don't have as much estradiol. We don't have as much estradiol protection. And once women hit menopause and lose estradiol, that changes cholesterol metabolism significantly. HDLs start to drop, and women lose the process, or it becomes less prominent, a process called reverse cholesterol transport. So what happens is, and this is cholesterol metabolism as well as plaque formation. What happens in most situations is that there's cholesterol floating around in our bloodstream. It's in the form of LDLs, HDLs, VLDLs, triglycerides, multiple different cells, compounds that will transport this stuff. And if the lining of the artery is injured, or there's just too much LDL floating around, it can sometimes, or if it's a certain type of LDL, it can get underneath the lining of the artery and deposit itself there. Now, that's a normal process. Bodies will have a mechanism to deposit and remove this stuff as it gets into the arteries. That's LDLs deposit it, HDLs remove them. So in women, when you're young, when you have estradiol, when you're of childbearing years, the HDLs are very robust and can pull out that cholesterol that's been deposited and provide a protective aspect. Men don't have that as much. And then when we look at people that have low HDLs, they don't have it as much. So once women hit menopause, lose the estradiol, that HDL protective effect starts to get lost. And so within 10 years, women's the risk for atherosclerosis and heart attacks has now gone from reduced to matching men within 10 years after having menopause. So it's almost accelerating once they lose estradiol. So then after a menopause, after a certain period of time, age-matched risk is about the same. So that's, one of the reasons why we have some gender differences, and, a little bit of an explanation as to how plaque develops. Because once it stays there and the HDLs aren't able to remove it, that irritates the artery. That irritates the area under the lining of the artery where it's deposited, and then that will trigger immune compounds, inflammatory compounds. And that creates a cycle of inflammation, more depositing of cholesterol or LDL, more inflammation, and then this lining, this pocket of irritation starts to grow, and then eventually it takes up space inside the artery and may burst. That's why we see atherosclerosis develop more in men, and that's how it develops as we're young, and maybe how people have a sudden event. Now, there are situations, and this is a large majority of people as well, where atherosclerosis will develop slowly, and the immune system can manage it and keep it controlled. But the plaque will still grow over time, and it becomes calcified. The way our body stabilizes plaque or atherosclerosis is to turn it hard, make it sort of like it's concrete. That's what it does when it turns it into calcium. So it makes it metabolically inactive, but it still starts to grow. And then eventually that will slowly encroach upon that lining of the artery, and that's when people develop chest discomfort slowly over time. It's called angina, and oftentimes shows up with stress tests or with regular activity, shortness of breath, things like that. So it's a slow process, and slow processes are difficult to assess what needs to be done, what changes can be done early on, and how it can be, what impact it can have later on. So this is coming into the discussion of changes in lifestyle and diet and things like that. We cardiologists we see a lot of people, and oftentimes there's poor education on what diet, and because there's a lot of conflicting information out there. But what we know is that diet and exercise are two of the key factors that can limit the effect of developing atherosclerosis. Why it doesn't get talked about is because it's a difficult thing to dial in, to have as part of the regular habit, and to do consistently over a long period of time. That has a surplus of calories in food. And this is something that can lead to an increase in inflammatory compounds. Too much sugar, too much calories in general overloads our body's ability to metabolize those calories. That ultimately leads to increased blood sugar, increased LDLs, and both of those combined will predispose somebody to atherosclerosis. So regardless of what medications you're taking, the foundational aspects of diet and exercise are vital, not only to help control the caloric load and your metabolism, but even your body's ability to metabolize what you're putting in. The more exercise we do, the more controlled our diet is, the better our muscles are to metabolize, and that's often one of our best tools to metabolize all of what we take in.
While you were explaining about how hormones protect women, actually, This is why maybe I kept hearing since I was like maybe in my 40s, like, oh, you have a kind of a high LDL, but your good cholesterol is also high. So it seems like, and then suddenly, like you're explaining, I started seeing my good cholesterol getting lower and lower after menopause. Is it why you also are a hormone expert? So you saw that, you can help women and men probably as well with hormone support.
Absolutely. My education started with the conventional cardiology, and I learned everything I needed to learn through medical school fellowship. And we were not taught about hormones. We were not taught about how to treat the heart disease without medications, with things that don't require a prescription. And then we also didn't have really good tools to treat this slowly progressive disease. So finding things that were working with chronic diseases and working on prevention led me to looking at hormones, looking at functional medicine, and peptides for that matter. So hormones are, I think, they are one of our original regenerative tools. They're natural, and we do ourselves a disservice by not taking advantage of those. And also, in medicine, especially in cardiology, aside from a heart attack or emergencies, there's not too much that I can do to help somebody feel better and improve their quality of life. Oftentimes, it's write a prescription to lower cholesterol, and then, in best case scenario, somebody just doesn't have side effects, but their numbers get better. With hormones, not only do I see a positive impact on the metabolism and risks for heart disease, but oftentimes people feel better.
It's very interesting. While you were talking, it's in front of me, the gender-specific differences. Now I started understanding, but please explain more, because I see that in women, smoking increases heart disease risk more in women than men, obesity and metabolic syndrome the same way, high blood pressure the same way, diabetes the same way. It's interesting, like why women more? Because of the hormonal changes?
I think so. And often I think that the studies also look at women that are most often in their postmenopausal years. So we have to look at the population that's being examined in those studies as well. Because once you've lost that hormonal support, and that goes for testosterone too. I focused on estradiol, but women lose testosterone too. And even though you don't have as much testosterone as men, it still plays a vital role in your metabolism.
When the other day when we were chatting, you kind of told me like everything we spoke about, like I was asking, what about atrial fibrillation? What about arrhythmia? What about plaques? What about this? What about that? And you keep pointing to inflammation.
Yeah.
So then it's not always the plaque. It can be so many different aspects of the heart.
Yeah. When we look at what makes plaque, what contributes to the formation of plaque, there are multiple things, and it's not just any one thing like cholesterol. And this was the fallacy and sort of the teaching that happened back in the 1950s, even up into the 80s. It's only been in the past 30 to 40 years that we've really started to understand that inflammation plays an integral role in the formation of atherosclerosis. And the ways that we look at inflammation are oftentimes through blood tests, but they're specific blood tests. And the way it weaves its way in is that inflammation can either cause irritation to the lining of the artery and be why cholesterol gets deposited, or it can continue to propagate a plaque, because once it's formed, the immune system will start to get triggered and go to it to try and control that inflammation and localize it. Once the immune system does that, it triggers a cycle where more things will go there. It'll try and control it. Maybe it will or won't, or it gets overwhelmed. The immune system is going to continue to be stimulated, and then it's more of an inflammatory process than it is just a LDL or a cholesterol process.
Let's talk a little bit about cholesterol, because, this cholesterol thing, it's like crazy. Little reels that I put on my Instagram, the conversation that I did, only a couple of minutes, we spoke about cholesterol with Dr. Yurt. it went viral. People started like, oh, they start fighting. People start fighting.
Sure.
Oh, this is too high. This is too low. I told you so. Don't eat this. Don't eat that.
Mm-hmm.
Eat that. So what is cholesterol? Let me ask you that, because it seems like it's a very important. What do you call it? What is cholesterol? Like a product of our?
Yeah, it's a building block. It's a biological. It's a compound that we eat. It's a compound that our body uses for fuel. It's a compound that is part of our cellular membranes. It's used as an anti-inflammatory product, and it's used by our immune system, and it's used to make our hormones. So when we look at what the LDLs and HDLs and triglycerides carry, they carry two compounds. One is cholesterol and one is a triglyceride or a fatty acid. Let's call it a fatty acid. Okay. They carry two of these things inside this round sphere, and it floats through our blood. And as it floats through our blood and it contacts different tissues, they will pull out the fatty acids. This is what happens the first time around. Pulls out fatty acids, uses it for fuel. And different parts of our cell and different cells use it in different ways. All right, so that will get pulled out, and then what's left after that may be more of the LDL. All right, and which is a sphere that's got mostly cholesterol, but very less fatty acids. So when that goes around, that goes to areas where there might be inflammation, where there's areas that need that building block to support the cell membrane or to produce hormones to help the immune system. So it has multiple different functions, and these are positive functions. But the challenge is that when we have too much of this, because when this floats around in excess, then it creates inflammation. It creates an overactive immune system and overactive problems. The human body works best in a window, always, in balance. We don't like too much of any one thing or too little of any one thing. So when we look at LDLs, when we have too much of it, it can propagate inflammation. When we have too little of it, this is where it gets interesting. It may impair normal function, but it's hard to detect that. That's the first thing. Also, it can be something that things like cancer and infections and viruses can hijack. So,
what is too much and what is too little?
Well, that's a good question, because it's we've looked at population-based approaches to determine what's a good average and what is a good range for people, and that really hasn't worked well because everybody is different. And this is where it comes down to having to have an individualized approach to your patients. We can get a range of LDLs, but what are the HDLs? What's the balance? How well is the patient able to pull cholesterol out of the arteries despite how much they're depositing? And then the other aspect of that, which is now what I like to consider the more modern individual assessment of who needs treatment and who doesn't, is adding imaging, adding a coronary angiogram. Now, you can do that with this CAT scan. You don't have to go and get an invasive test. When I was trained, that's the only way you could do it. Now, you can get a contrast CAT scan, a CCTA, that will look at the arteries of the heart and tell us in detail if there's calcium, cholesterol, or inflamed cholesterol. And when we can see that and combine that with blood tests, then that really tells me who needs to get cholesterol-lowering therapy and who doesn't. Without that imaging information, we're having an uninformed dialogue, because a person can have high cholesterol, but it might be high LDLs, but it might be the type of LDL that doesn't cause any harm, because there are big LDLs that don't really deposit stuff. And then there's really small LDLs that are like cannonballs that do a lot of damage. And we can test for that. And then also take a look at pictures to see what kind of plaque or damage might be done. And that really is how I tease apart who needs to get treated and who doesn't. There's also an expression, plaque begets more plaque. So if somebody has already got a metabolism that's deposited a lot of atherosclerosis, then unfortunately they're going to be more prone to it as they get older. And we can slow it down and maybe reverse it a little bit, but they're going to be more prone to it. So they need cholesterol lowering therapy and inflammation control. But if somebody doesn't have a lot of plaque and they might have large, buoyant LDLs that don't deposit much, there's no urgency to lower their cholesterol, and we can watch them, and we can do a scan every 5 years, and we can control the inflammation and maybe use some supplements or something that's not pharmaceutical. Use lifestyle, use diet and exercise.
Based on the norms, I have a high cholesterol. Luckily that I have Dr. Yurt that is not worried about it. Because as probably you know as well, because you guys work together, I had a CT angiography, and then you guys looked with Cleary, the AI, to see if there anything missing or they couldn't catch it on the imaging, and it was all clean. I had an operation 2 months ago, and for that I had to go to a cardiologist to do an effort test. When the guy saw the blood work, he goes like, you need statin. Like without looking to anything that you're saying. It was just basically without seeing the other things like ApoB, whatever, all these other stuff that is. So how so? It seems like, there's also a huge debate in the field, which is actually, it shouldn't be even a debate, but there's too much statin is prescribed without even the necessity, without looking too detailed into the problem. What are you seeing among these too much prescriptions?
I agree. I think that there was an excessive use. I think it was overexpressed. That's caused problems. I think statins are a good medication. I think that they have their problems, and no medication is perfect, but they have a very specific, important use. And when applied to those specific patients, they do well. It lowers inflammation. It controls LDLs. It controls oxidation, or the process of LDLs becoming inflamed. It's a useful medication, but I think that the effort to try and control atherosclerosis has been isolated to just LDLs, and it's been a singular focus that was misguided. When we look at the large studies that use statins, they're underwhelming. They didn't do as much as expected because it's a multi-layered problem. So using just one medication that has problems is not going to provide the results that we wanted. So the medication was applied to the whole population when it shouldn't be. It should be applied to specific people that show that they're going to benefit from it. And that requires a lot of work that wasn't done. We didn't even know back then, I think, who was going to benefit more from what type of intervention. So this is evolving medicine, and I think that we're also trying to look at old data that may not have been, old studies that may not have been as useful as we had once thought. But I do think that there was an overprescription of statins, and we can probably zero in on who is going to benefit more and get better outcomes that way.
I also heard from a couple of different people that when people are given statin, unfortunately, as a side effect, but it's not like a side effect, like a physical side effect. It's a thinking side effect that, I'm taking statin, therefore I can continue eating the junk that I continue to eat. Because it's going to lower the cholesterol and it's going to lower the inflammation.
Yeah, that's a fallacy also, because we can't, everything requires a lifestyle change in diet and exercise. So if you want to reverse disease, if you want to regenerate, and when we're talking about a longevity space, if you want to improve your health span, then doing things like diet, exercise, sleep, stress reduction, social contact, all of those things are going to have a bigger impact than just taking a little pill, because it changes the mindset, it changes the whole system. And that will augment what is being done with the medications. And, if you don't do those basic things, then you're agreeing to a lifetime of medication, when maybe we can do a holistic or a global approach that may be able to get rid of some of those at some point.
I see that. I just had a blood work done, and I see reduction in all the cholesterol levels. I did use red yeast rice, but I also had, interestingly enough, 3 EBOO sessions and 1 plasmapheresis.
Sure.
So which one do you think it's more effective? So probably I used about like 3 months of the red yeast rice.
Each one of them has a different effect. So when we look at plasmapheresis, it's going to be the most effective at reducing your LDLs and cholesterol. When you look at genetic conditions where people have extremely high LDLs and they have a very high risk of atherosclerosis, they often require a plasmapheresis once every 2 weeks, maybe once a month, and it will lower the LDLs and cholesterol effectively. But then the body will rebound and it'll reproduce and come back after 2 to 4 weeks. So it's a short-term solution, but the most effective. When you look at red yeast rice, that's a more chronic, day-to-day change that you can take. It's an effective way of lowering LDLs slightly. It works on the same enzyme as a statin does. So you're essentially taking a weaker form of a statin. The challenge is that you also have to take a higher amount of it. Oftentimes people take a low dose of a red yeast rice and it's not going to do that much. There are other compounds out there that I like that can have a more effective impact on your LDLs. There's something called tangerentin and nobelatin. These are derivatives of bergamot, so citrus peel. There's also another one called bergamot itself is a citrus peel extract. And so those three are different types of compounds that I use a lot of. I'll use aged garlic extract, which is very good at lowering some of that inflammation that I was talking about. So there's multiple compounds out there, but they're mostly plant-derived, and oftentimes it require many pills.
Let's talk a little bit about the hormones. Are there like a good range of hormonal levels to help women and men to prevent these heart diseases?
Yeah, when we're looking at, specifically with women, estradiol ranges between about, and these are units that we use in the U.S., about 75 to 100. That's about the range that we shoot for to see the cardiovascular benefits of estradiol. And that's often what range we shoot for postmenopausally, because if we go too high, then you run the risk of cyclical problems, and it's not as, it's higher risk of side effects. Testosterone is more variable. Men, we could go from a total range of 750 to about 1200 even. But more what's relevant is the free testosterone, which is much lower. And free testosterone is what is available for the body to use more freely, more readily. It's the type of testosterone that's not bound up by different proteins. And it's what's being used for basic daily functions. That range, around 125, maybe higher, 150. But for women, women have a much more variable tolerance to testosterone, and we can have women that are very sensitive to it, and they'll get to a range that's much lower, with a total testosterone of anywhere from 50 to 150, and they may feel something. And then some women can tolerate a testosterone that's up into 250 total, or 500. So really, it's very individualized. There is an individualized aspect to men too. Where that comes in is how sensitive the patient is to the testosterone. The receptors have a specific sensitivity that's genetically determined, and that can really impact how much a person needs.
And you mentioned peptides. You use peptides, you said.
Yeah.
Are they specific peptides just for the heart disease that you use to prevent, let's say, not to...
Yeah. I love peptides because they are compounds that speak to our entire body. So they're messenger molecules. They're molecules that our body often makes on its own and helps our body function more efficiently. And our body, the way it works is to be the most efficient it can be And to do that, it's not going to have a singular job for a singular peptide. It's going to have one peptide or one molecule do multiple things. So what I love about peptides is by giving it for improving cellular efficiency, improving overall health, it improves multiple different systems. So when I look at what types of molecules I use for heart health, it really depends on where a patient is coming to me with. If they're post-operative, then I'm going to use things like BPC, thymosin beta-4, testosterone, to help improve their post-operative recovery. And then once we get over that, maybe use things that help improve vascular health, like BPC. Continue with the growth hormone stimulating agents, and then use molecules like SS31 or other things that help mitochondria. So it's not a specific heart peptide, but it's multiple peptides that influence the whole body in a positive way.
And you mentioned just before we were starting GLP-1s. They're they're the most spoken and the most suggested at this point peptide for so many reasons besides the weight loss.
That's right. And that's a perfect example. The GLP-1s have, originally designed for diabetes, see profound benefits in weight loss. That by itself reduces risk factors for heart disease from a secondary standpoint. When we look at what it does directly to the heart, it improves myocardium, the health of the heart muscles themselves. It improves the efficiency of those cells. When we look at the vascular system, multiple levels in which it helps the vascular system.
It helps to all these.
When you look at the endothelium, that layer of the artery that is the first layer, that's the most protective layer, it improves the health of that layer, improves the efficiency so that it makes more compounds like nitric oxide or anti-inflammatory compounds to protect it. It makes the cell more efficient. That's ultimately what GLP-1s do. It helps the different parts of the inside of the cell function more efficiently. So what we see showing up in the larger scale is when the pancreas functions more efficiently, we control blood sugar. When our gut is functioning more efficiently, it controls our gut-brain axis. So it controls our hormones, how we eat, our gut microbiome. When it controls how efficiently our muscles are functioning, it helps our muscles pull sugar, glucose in more efficiently. So it does that to all of the tissues that have that receptor. Those receptors are in the brain, they're in the lining of our arteries, they're in our heart, they're in our kidneys, in our bone, in our gut. So many different tissue types have a receptor for that molecule, and it helps all of those tissues function more efficiently. So back to the lining of the artery, that endothelium functions more efficiently, becomes more protective. We reduce inflammation. We reduce the LDL depositing, helps the liver so that it makes bigger LDLs instead of like the really small, aggressive, cannonball-like LDLs. So, it's a global agent that helps the whole system.
If the person doesn't need to lose weight, what are the doses? Like, what do you consider a microdosing?
Yeah. Anything that doesn't suppress appetite significantly, you would consider a microdose. I often use semaglutide at about 0.25 milligrams per week. Sometimes we could go a little longer, and even you could push it to 0.375, 0.5, depending on their tolerance. Microdose is something that's subperceptible and something that's not going to impact much weight loss. If we're going to use tirzepatide, that's going to be 2.5 milligrams per week, pushing up to maybe 5 or even lower. A thin person might be very sensitive to it, so we go with lower doses. So it's an individualized thing. But even that's something that's being employed in a lot of different longevity clinics because this is such a powerful, useful agent that we want to try and give people the benefit of having even a small exposure to it to help them out.
Something is make me very curious about this whole heart attack thing. Why younger people, when they have a heart attack, they just suddenly die on the spot, but older people have these symptoms and they have a time to go to the hospital and they're saved.
Yeah.
Basically.
That's part of that is how quickly it's developing, and the other part is where it's developing. So if you remember earlier, I was talking about depends on what artery it may develop in. One of the arteries called the left anterior descending, which is the LAD, often called the widowmaker, because
widowmaker, because the guy dies and the wife is a widow. Okay.
Yes. Yeah, this is where we see the most where we see plaque develop often. It's in an area where it's up close to the origin of the artery, and if it blocks the artery quickly, which it often does, it will kill more than 50% of the muscle of the heart and cause sudden death. That's the situation. Usually, it's the location of the artery, because that artery in particular supplies so much muscle of the heart that if it gets blocked suddenly because a plaque or atherosclerosis has bursted and caused an acute problem, that's a patient that it doesn't have much time. They need to get to the hospital quick, and they will have that sudden pressure, chest discomfort and sweating and shortness of breath without doing anything. If it develops in other arteries, it can have similar symptoms, may not be exactly the same, but there is potential for the body to be able to compensate by supplying other areas. The entire heart is not compromised, and so they can make it to the hospital to get treatment. Oftentimes that LAD is what kills people, and so they can't make it to the hospital. They can't get there to get treatment. And then also, we see more people dying of heart attack younger now because we have so many more toxins in the environment. Despite all of our efforts to try and control what we eat and our education about lifestyle, diet, and exercise, the world is continuing to get more processed food, more higher caloric content that's calorie dense but nutrient poor, and is not moving as much. Obesity is on the rise. These are all things that promote atherosclerosis, even in a healthy individual. If it's somebody that's genetically prone to having plaque, like a South Indian or a Latino person, or even Asians, then they're going to get heart disease at an even younger age.
I also listened somewhere that, older people, because it takes a while to build these plaques, therefore the body start adjusting itself and develop new blood vessels to compensate the clogged arteries.
Yeah, and that's great. That's a great point. In people that are prone to atherosclerosis but do have good diet and exercise, have a good lifestyle, they may still develop plaque, but their body is better at stabilizing it. So as it grows in smaller increments, and nothing bursts rapidly, but it grows slowly. And then that's when we start to see people in their older years develop chest discomfort. And that's why, unfortunately, we don't have a solution for stopping atherosclerosis. I mean, we can minimize it, but the longer we live, the more prone we are to having atherosclerosis. But it's okay to have the small amount, as long as it's not impacting the blood flow of the artery and it's not inflamed or growing rapidly.
What is the youngest age that you would suggest someone to have a CT angiography? Because it seems like, screening is super important. All that I'm hearing is screening. And what would be the ages that one needs to start doing it? Because, I was only 50 something that I had we look to the heart.
Yeah.
I'm sure things develop before that.
They do. And I would recommend doing it before 40 years old, getting a full lab panel and getting some sort of imaging, because it's CCTA, because it may be expensive, but if it comes back abnormal, then that's saving your life. And it's an expense that's worth it.
And you said every 5 years?
Well, it depends on what we find. If there's very minimal disease, you could push it out for 5 years or later. If there's moderate to severe disease, then we're going to start multiple therapies, and we want to track that. And we may, depending on what we find, do it annually for a few years and then push it out. or every 2 to 3 years. But it really depends on what we find with that initial testing. And you could even go further if it's very clear.
Dr. Husain, I also, in these podcasts, I try to educate people and I learn a lot. The other day, I was interviewing another doctor, Dr. Stephanie Estima, and it's the first time I heard that men and women experience so much different symptoms when that heart attack is coming. We all, you have a thing on your left arm, a chest pain. Women is experiencing totally different symptoms. Can we, from a cardiologist, it's better to hear from you than anyone else. What are the symptoms men would feel before a heart attack is coming and what women would feel?
Yeah, that's a great question. The men classically, and this is where the symptoms were the profile. That's how it was created. It was created mostly with men in mind, and because that's who was studied. And this happened back in the 50s. So that's why we have this symptom description, and it's only now being updated. We look at the men have classically it's chest pressure, retrosternal, so right underneath the sternum midline, maybe a little bit towards the left. Crushing, like an elephant is sitting on the chest, or squeezing, and with maybe some discomfort going to the jaw, left arm, oftentimes shortness of breath, sweating, oftentimes a impending sense of doom or anxiety. So those were some of the classic symptoms, and many women in the past were not accurately diagnosed with heart disease because they didn't have those classic symptoms. Women have a different symptom profile. They can feel abdominal discomfort. They can feel, lower abdominal discomfort here. Sometimes just shortness of breath. It can be very variable. It's not as well delineated as we see with men. And even men have alternate or atypical types of anginal symptoms. Upset stomach as well, maybe something right-sided on the right side of the body instead. But the thing that makes them, that ties them together is if they're having discomfort during exercise, if they're having some of that pressure or reproducible discomfort during high output exercise, and then it resolves after you go back to normal. That's always a red flag for me. If somebody tells me they're having chest discomfort at rest, but it goes away when they exercise, that's often very reassuring. But if it's happening reliably with exercise and then goes away after rest, that's a concerning sign for me.
Oh, wow. Okay. Everybody's going to be paying attention. I have so many people my friends watches the podcast a lot and they say after each episode, I start questioning, do I have this and do I have that? I said, why are you not focusing to the good things? In order to prevent it instead of reading yourself and listening to yourself too much. What would be a message that you would like to spread for people to have a better heart health?
Yeah. I think we can use a lot of medications. We can use a lot of prescriptions and supplements to control your heart health, to control your risk. But we should never lose sight of the foundational things, which are going to be diet, exercise, sleep, stress management, social interaction. Those five things are foundations to good health, all types of good health, and cardiovascular health is not an exception. I think that and make sure you get screened, because the largest population of people that die of heart disease never make it to the hospital, and they may not have a family history. They may be the first person in the family that has that problem. And it's also unfortunate, but we live in an increasingly toxic world, and more people are showing up with inflammatory conditions like heart disease. So make sure you get screened appropriately.
Can you also share which blood markers? Because mostly, they only look to good cholesterol, bad cholesterol, and total. Yeah. What are the detailed list of blood markers they should ask to their doctor if their doctor are not looking for?
Certainly you can look at a basic cholesterol panel is useful. ApoB is helpful to determine more specifically what type of LDL you might have. If it's and looking at ratios of ApoB to LDL help to determine that. You can actually get a measurement to look at what type of LDL you have, which is a small dense LDL, an oxidized LDL. And you can also, and what's a genetic risk factor is lipoprotein little a or apolipoprotein A. That's important. Those are just the cholesterol markers. When we look at inflammation markers, I want to see a C-reactive protein. I want to see something called LPPLA2 and myeloperoxidase, MPO, is sometimes helpful to see who is acutely at risk. Those are some of the basic inflammatory markers, and then combine that with imaging, and we get a very thorough picture.
Dr. Husain, thank you so much. This was super, super important and very informative, actually. This was like a special class on heart disease, because it seems like people need to really pay attention to their lifestyle and their diet, their exercise, in order not to get it.
Mm-hmm. Yeah. Well, thank you for having me, and I appreciate the opportunity to spread the word, and I'm grateful to be on your podcast. So thank you.